Hello, everyone, and welcome to our final webinar for 2024. I'm Chad Cruikshanks, Senior Director of Marketing at Nucleus RadioPharma, and I'll be your host for this session. We're really happy to bring you to 2024 year in review. Our topic, greatest hits in radioligand therapy, a year in review and prognostications for 2025. Joining me for the call today will be Geoff Johnson and Kathy Spencer-Pike. Before we get into the content, just a couple reminders. This webinar is being recorded and will be available for review in the future. And also, if you do have questions today, please use the Q&A function at the end of the webinar. We will go to Q&A and I'll pose any questions to Kathy and Geoff. With that being said, I'd like to introduce Geoff Johnson, our founder and Chief Scientific Officer at Nucleus RadioPharma, and also Kathy Spencer-Pike, Chief Commercial Officer, Nucleus RadioPharma. As we kick off, Kathy, with the greatest hits in radioligand therapy, I pulled a handful of headlines to share, kind of reviewing 2024. So I'll pass it over to you and Geoff for the discussion.
Excellent. Thank you so much, Chad. And good morning, good afternoon, everyone. Thank you for joining us on a Friday before the holidays. I think everyone is probably in a mad rush and race to get towards the end of the year and get into the holidays and hopefully some really well-earned time off with family and friends. But before we jump in and put a bow on 2024, Geoff, I think it would be a miss if we didn't really look back, as Chad said, and look at the remarkable achievements and milestones met in the radiopharmaceutical space this year. So to kind of start with a softball. As you look back and you think about all of the amazing, we saw some on the slide, what really sticks out to you when you look back at really notable accomplishments and achievements for this year?
So there's a number of things. I think there's a little bit of a delay, but we are making progress to get PSMA therapy for prostate cancer into earlier lines of therapy. So this is what everyone thought was going to happen. You just saw on the slide the three main trials, two now recently, a third one showing positive on the primary endpoint of progression-free survival with several versions of lutetium PSMA from three different companies. So I think as we look at that and say, okay, we're going to expand now, almost definitely, but we don't yet know because the FDA hasn't ruled on it, from late stage prostate cancer to pre-chemotherapy, which is going to probably triple, depending on where you are, which hospital, maybe double, maybe even quadruple the number of patients that would be eligible in those hospitals that are actively treating. So that's a huge win for patients. As a physician and the patients, I think everyone's excited about that. And then going further, PSMA addition, we'll see if that one closes out to say whether we can go even earlier, even while they're still on hormone therapy. So clearly a major push in prostate cancer. For me, I'm really excited about going into all the different types of cancers. So as a nuke med physician radiologist, I'm not wedded to any specific cancer. This is a technology that we can bring to any kind of cancer. And we've got trials that are moving forward in so many different kinds of cancers now. We got breast, we got pancreatic cancer, hepatocellular cancer, melanoma, small cell lung cancer, breast cancer. We're really going out and expanding. And as you see that depth and breadth percolate forward, we've got a lot of really exciting opportunities, and there's a lot of things that are excited about here. One is I think we touched on it before, but getting closer to a deal to say we can get better reimbursement for the imaging radiopharmaceuticals. That's a huge win. A big debate about release criteria for hospitals from the Nuclear Regulatory Commission, NRC. There is some debate about that. There are some pros and cons there, but we can touch on that. And a whole group of companies that are really thinking and scientists thinking, okay, now this is really moving forward in radiopharmaceuticals. Can we take the things from ADCs? Can we take different types of ligands forward? And then also, we're seeing success in multiple different radionuclides coming forward, and the alpha emitters moving closer to approval along there. few bumps in the road with supply chains, which is, you know, something we deal with here, a bunch of barriers we're trying to overcome, but overall, it's been a fantastic year. Yeah.
Holy cow.
Yeah.
You covered a lot of ground there. I'm gonna
Yeah.
go back to a few things that you mentioned and go a little deeper. So on the FDA ruling on Novartis's pursuit of label expansion.
Yes.
Timing. Do you get any kind of, in your position, any idea of when that timing will come? When they'll make a decision?
Yeah, so as we talked about before, it got delayed from the time frame we thought it would be,
Right.
because of the hazard, the hazard ratio, the ratio of patients who died on the therapy arm versus the control arm because of the crossover. Unprecedented number of patients who were on the control arm wanted the therapy and they crossed over, greater than 80% in all three of these trials, unprecedented, which then statistically creates a problem with the secondary endpoints of overall survival. So we're there now. It's on the right side of one. And I think we can anticipate, barring some other problem, that there's a really good chance that we'll get an expansion of the label. In terms of the timing, you know, it's hard to predict that stuff. I mean, you hear different things. I would say in the first half of next year is what I'm hoping for. You know, cross our fingers.
Yeah, absolutely. And so as you also mentioned, all of the various cancer targets now that are being explored, which is super exciting.
Yep.
If you had to kind of put your chips on one particular target, what do you think will emerge first as the focal point?
Okay, so there are kind of 20 targets that are being developed. There's a bunch of exciting ones, and they're in all different phases. Some of them are literally taking targets that we already have and expanding them out. So, like, look at Ray's Bio's trial with breast cancer. You're looking at somatostatin receptor, which we knew from the beginning of octreotide was expressed on a lot of different cancers, and breast is one of them. If that with an alpha emitter can be effective, then we can take a drug that we already know the toxicity of, and we can and has the chance of being FDA approved for neuroendocrine tumors, and bring it to a much bigger population. And that's also a neat trial because they're bringing in immunotherapy, which, you know, I'm excited about.
Yes.
But in terms of new targets, we've got DLL3, we've got STEAP1 and STEAP2, you've got maybe some debate about FAPI, but some new exciting versions of that. And if FAPI could be effective, it could be many different types of cancers. And there's an exciting one that Ray's got that is now BMS, which is I'm excited about the glypican-3 target in hepatocellular. That looks really good on imaging. These are going to be early phase trials as we're going forward, but we could spend the whole hour on all these different ligands and targets.
Can you expound just a bit on the FAPI a little bit? Because I know there's a lot of sentiment and thoughts, good, bad, and everywhere. So why has that been a challenge?
Yeah, so let's break it down for the audience a little bit. So FAPI is fibroblast activated protein, and then the I is for inhibitor. So fibroblast activated protein, right? So it's expressed on the fibroblasts that are mixed in with the tumor in most cancers, with the exception of certain sarcomas or soft tissue and bone tumors, where the actual cells of the cancer express it. So there are trials coming forward to target it with sarcoma, which is just a straight play to bind to the cancer cells, just like anything else. But when we look at it in imaging, there are people who have said this is as good or even better than FDG. We can see tumors everywhere. Why? Because in many tumors, half or even more than half of the actual tumor are the cells of the body's response to the tumor. So you look in the microscope, you look at a pancreatic cancer metastasis, and 80% of it might be fibroblasts in terms of the volume. So that gives you you could call it a tumor environment target. You stick to the cells near the cancer and you radiate it. There's debate about how well the beautiful imaging that we see on PET scans translates to therapy. Right? Yeah. So we know that with, say, FAPI-4 or FAPI-46, within an hour after injection or even 15 minutes, it's on the tumors and it's dramatically cleared from the blood, and you get a beautiful scan. So you might say, oh, as we know, the image has a good prediction of the outcome, but it's not perfect. One of the things we found is that FAPI tends to cycle off of the receptors. So for an image, you're taking a picture on a PET scan, how much drug do you have in each voxel at the time you take your picture? That's what SUV is. That's what a
Right.
PET scan is, right?
Okay.
So, but if you wait, you go, okay, now it's going to be radiating over time. If it doesn't stick and stay, if it's
Yeah.
not sticky, the amount of radiation delivered to the tumor may not be as
As
good.
effective, yeah.
So that's where we're debating. There are newer versions that stick and stay. There are various different. There's even some companies coming out with ones that chemically covalently link to the target. So
Wow.
they basically can't fall off, that are being tested. That's a tricky thing to do in the body, but that's looking like we may have a winner coming there as well. So the stick and stay is part of it, but then there's a debate about, well, if you radiate the cells around the tumor, maybe you shrink the tumor, but maybe you are or aren't killing as many of the cancer cells as you need. And those are things that we'll have to see. You know, electrons from beta will shoot a couple of millimeters across thousands of cell diameters. Alphas are going to kill the cell you're on. People have shown that you still kill cells at a distance, which is surprising because maybe the cells are rupturing. You get this bystander effect. And the detrifuse, that's wrong. The particles of the cells that bleb out and things can link and stick to other cells nearby and actually kill them. So we don't know. But I think there's excitement. But right now you've got trials like Lumiere going through phase 1 and dose escalation, and the amount of positive signal, the amount of response we're seeing. It hasn't blown people away yet with that particular drug. But going forward, they might hit the right dose, and then also we've got other drugs coming along the lines.
Thank you for that. And as you're mentioning kind of the imaging and therapy, I'm noticing certainly on my front, and I'm curious on yours from this year's, more and more companies coming to market in that kind of companion tandem approach with a diagnostic to go with their therapy.
Yeah.
Do you think those companies have an advantage over companies that are not developing a diagnostic along with their therapy?
I think with a perfect drug, if you gave it to a patient, they have no side effects and it's 100% effective, just give them the drug. Like you don't need anything else, right? So the question really comes down to, do you know that there's a distribution of cancers in the population, some of which express the target and some of which don't? Because the initial injection of the PET scan is basically a whole body tissue stain. Like it's like you're looking at pathology on every single tumor, and you're measuring the amount of drug that's in the tumor, right? So depending on how much imaging you do, you can just say, yes, all the tumors I see have expressed the target, which is basically what we do in our current practice. We say they're expressing the target. Or you can even calculate how much radiation the therapy will deliver. If you have a perfect theranostic pair, and if your imaging can stick long enough that you can actually measure, okay, if I give the therapy, it's going to stick and stay in the tumor in this amount, and I can calculate the dosimetry, how much radiation exposure. We can get into a lot of debates there. I mean, that's kind of hard to do with longer drugs in the workflow of the patients. But if you have a population of patients, some of their tumors are negative, some or all of their tumors are negative, where you really don't see any drug going to it, there's no question that that's not going to be effective. We all kind of agree on that, and there's good data to support that. If you look at the VISION trial, they really broke out in subsequent studies saying, okay, what happens when you have just enough PSMA activity versus a lot of PSMA activity on the PET scan prior to the therapy? And the data really shows that if you have a really high amount of PSMA activity on your 1 hour PET scan, you're probably going to have a better efficacy. But a lot of those other categories, they blend together. In other words, you get a little bit versus moderate amount of activity doesn't change the prediction very well, which goes along with to say, we know that we're not, with most of these drugs, radiating the tumors as much as we'd like. Okay, where some people would say that's underdosing, but you have to balance it with the side effects. So if you're not getting enough radiation to overcome the resistance in the tumors or the environment, then slight differences in the tumor types or even where the tumor is predict outcome in ways that the dosimetry doesn't give us enough information to predict. So when you look at to pivot, like, so you look at trials like the SECURE trial with clarity, they're going to a much higher
Higher.
dose, getting up into like over 300 millicuries per dose, trying to overcome some of those barriers. So I think we're pushing the trials to a much higher dose now. But, I think when you look at the imaging in general, it absolutely helps predict outcome, but you really have to see the outcome and then correlate it back to the imaging for a particular drug.
Excellent. Well,
Yeah.
you touched on also the fact that, there's a lot of sometimes discussion that that the therapies are not dosed high enough to get the most optimal. And it sounds like what you're seeing now with a lot of clinical trials is really pushing the boundary a bit more. And I don't know if that could be characterized as taking a bit more risks, but just starting out a little bit more aggressive with dosing.
Well, I mean, there's this whole movement of dose optimization where, I don't think anyone thinks the dose of Pluvicto has been optimized, but it is effective and it is relatively safe, and it works. So and it was a fast way to get through the trials, and it was based on data we already had. So I don't fault that plan, although if perfect was the goal, we would have optimized the dose better.
Yeah. Do you see, well, and on that note, kind of a random follow-up on that, do you see any potential to go back and redo the label?
Yeah. There's all kinds of supply chain implications and kind of how would you do that? Yes, that opportunity is there. And so if you said, I want to increase the dose to the tumor, you have different ways to do that. So you can also say, okay, yes, I want to, instead of giving 200 millicuries, I want to give 500. Okay. And you could do that in the clinical trial, but you could also say, well, I want to give more cycles. Okay. So that's a trial that's moving forward to say, okay, rather than 6 cycles, the patient could go beyond that and go to 12. There are, or you could combine it with other therapies that make the radiation you're already delivering more effective, right? So hormonal therapies, chemotherapies, immunotherapy, all these things are coming, which is, I think, what you're going to see a significant growth in is, okay, it's kind of hard to take a supply chain with 200 millicuries standard, all the data we have, and ramp it up to a higher dose. There are different ways you could do that, although I haven't seen these trials like you kind of split doses where you say, I'm going to give 200 millicuries, then like a day later, I'm going to give 150, right? So the supply chain is similar, but those are all things that are ongoing and being discussed. Yeah.
Exciting. I want to return to the CMS decision to unbundle.
Yeah.
So have you seen any upside to that yet? And is it as big of a quote breakthrough from a reimbursement perspective as we believe it to be?
So we're talking about on the imaging side, again, with the theranostic pair, imaging and therapy, for SPECT and PET imaging agents. And this isn't just for cancer. There's the CY25 ruling coming out, and it isn't quite done yet. It's still moving through the government, and when it was launched, and the numbers, you may have heard that people are batting back and forth exactly where these cutoffs will be and the reimbursement. I'm going to ignore all that and just think of it as a broad picture. I think it's a huge win. There will be companies that win and lose in this process, but for the whole field, I think it's a huge win. And for our patients, it's a huge win because, as we talked about before, if you're in a hospital, if your patient's in a hospital that has to pay, say, I'm going to pick a number, $3,000-$4,000 for an imaging radiopharmaceutical, but gets reimbursed for the entire scan at less than $2,000, which includes bundled in it the radiopharmaceutical. That you got to look at that and say, well, how do you convince that hospital to keep offering that scan?
Right.
Which is what happens after approximately 3 years of a reimbursement with these imaging agents. And I don't think the imaging drugs are going to get any significantly cheaper as they're developing. There's a lot that goes into that. So this will allow reimbursement that makes those hospitals whole. So you could look at a big place like Mayo Clinic where I practice and say, well, in the grand scheme of things, there are other ways they can move things around. They can handle that, right? But for Medicare patients, which is what we're talking about here, that's a death knell for the continuation or even the launch of these practices. And then it snowballs and say, okay, well, now that means you can have a long-term investment in an imaging drug. You look at PYLARIFY and it's close to $1 billion. and you look at that kind of roadmap of investment and encouragement for industry to really develop the imaging agents, and then the theranostics go with it. So it helps industry investment. It helps for penetration of the market, which we're way on. So that's the business side of it. But the patients in the community hospitals that can't get access to this,
Right.
if you don't have the imaging, you don't get the therapy.
Yeah. And so to your point, kind of unlocking so many more potential patients
Yes.
that really need these therapies.
Yep.
Excellent. That's great.
Yep.
All right, let's go back to clinical trials. Would
Yep.
you say, I'm going to use the word breakthrough. Would you say there were any clinical trials this year that surprised you in a really big way?
I think on the clinical trial aspect, not really.
Okay.
I think most of the things we've been seeing have been relatively expected.
Okay.
It was at the time, the crossover trials when that was first coming out, and there was 80+% of patients crossing over, and there was at least initially a greater than 1 hazard ratio, which means more people died on the therapy. That was surprising.
Yeah.
But when you look at the data and the statistics, you're like, yeah, that can happen. And then with time, it started showing that, okay, as the data matures, as we get more real data that we follow up on the patients, it went in the direction we expected. So that was a little scary and a little surprising. But in terms of, moving forward with new drugs in phase 1, that a lot of these drugs aren't going to make it. But there has been significant progress in a number of, here's one for you. So I'll go back to the Clarity one I mentioned before with the copper 67. The amount of efficacy that was seen early on in that trial was surprising to me. So it's kind of funny. So you give a patient a dose in a single dose on these studies, and a lot of people don't realize it. The radiation is delivered over the course of a few days, right? Maybe a few weeks, depending on which one you're using. But the tumors continue to die for weeks and weeks and weeks and months. And this is an interesting phenomenon that, we know from external beam radiation, and we actually saw early days of what is now called Pluvicto. But you go to a shorter-lived radionuclide with copper 67, and the prolonged response and continued decrease in PSA is surprising, because the tumors have a DNA damage and they don't die until they replicate. So there's this interesting phenomenon that we're seeing with some of these really short-lived radiopharmaceuticals still having efficacy way beyond when you give the therapy or when the radiation's done.
Exciting. And I suppose then the really only way to monitor that is continued imaging.
Imaging, and if the patients are producing a blood marker like PSA, that works as well. Yeah.
Excellent. So I'm going to switch gears just a bit, because we saw this past year, and I'm curious if you think this trend will continue into the upcoming year. We've seen a trend where big pharma, so of course Novartis was kind of first to the market. We saw AZ get into it, BMS, and so you've seen these acquisitions from big pharma to smaller. And I think you would probably say it's exciting to see that.
Yeah.
More investment, more attention,
Yeah.
more resources going into this space is just good for everyone all the way around. Do you think other big pharma will get into this?
Yeah, I think they will. I mean, they start showing signs of it. Along those lines, some of those big investments were in collaborations to develop new ligands, right? And there's a whole interesting, over the last year, especially investments in companies like Mariana and Bicycle, the bigger companies trying to get access to molecules that are both small, like the peptides we currently have, but are stiff, unlike the floppy peptides. So they have higher binding affinity. They stick much more tightly to the target. And other companies looking at aptamers and DARPins and like cyclic DNA and RNA and these molecules that have these small structures but high affinity binding, rapid to the tumor, rapid clearance, has been an exciting expansion. And that means that we're getting our fingers into all kinds of companies thinking about going into this space. We mentioned before those who are making ADCs, considering converting them. I mean, there were companies A lot of companies a few years ago were going after antibodies and converting them to radiopharmaceuticals. That can work. There are some great examples, but it's difficult because they don't clear very fast. So I think we're seeing a new trend to say, okay, let's start focusing on a whole bunch of investment around creating whole new molecules in this space.
Yeah, it is exciting.
Yeah.
Excellent.
Yeah.
I see Chad's popped up.
Yeah, I just jump back on. We came within the 5-minute mark of the end of
There
the
we go.
webinar. So I wanted to take a time for the Q&A. So again, if you do have a question, please use the Q&A function within Zoom. I do have a couple here, Geoff. One kind of a double part question.
Okay.
You've touched on this a little bit. Describe what you believe is the greatest opportunity and the most significant barrier to the advancement of theranostics.
All right, so maybe I'll start with the second one. Right now, well, there's a lot of barriers still, to be honest with you, but one of the biggest barriers is how do we get these therapies to be mainstream? How do we get them into the community hospitals and rad-onc practices and other places where 80% of our cancer patients receive therapy in the US? I mean, right now, we still have just an overwhelming majority of the modern radiopharmaceutical therapies being delivered at a handful of leading centers and a handful, and some of them are, most of them are academic, but some of them aren't. They're people who've really gone after this in other fields. But there's a lot of education that we need to do to teach people. We got to deal with the new release criteria. I don't know if I think we talked about that before. But you know, the NRC heard people's concerns about how clear that was for a small hospital to deal with. We need to develop devices and other mechanisms and education for how they can safely do these therapies at other centers. And so we can do, you know, trials beyond walls, and we can reach minority population and poor populations whose data we need, so we can get the therapy to them. So that is a huge barrier. I think Nucleus is really working on a lot of these things, ways in which we can help with the transport, ways in which we can educate these hospitals, and ways in which we can bring devices that can help them do the injection. That is, we are under-penetrating the number of places and people that we can treat with the therapies we already have. And we need to also be able to compete with shelf-stable drugs, okay? It's not enough to say, okay, we need to have figured out how to treat a patient with these therapies and teach people. If the patient's with you and you can't treat them for 2 weeks because you have to wait for the ordered specific drug to be made and shipped, you're not going to have a drug that many people are going to want to have. They want to go now. Yeah, and so we need to get the turnaround time and the whole system just dramatically improved. You know, we're already seeing some. Okay, I'll stop there. What am I most excited about? Yeah. I've already touched on a few of these. I'm most excited about the fact that we're going after all kinds of cancer. Absolutely. We're getting new minds, new companies, new technologies into this. I mentioned the DARPins and aptamers and these other molecules that don't stick to the kidneys as much. So there's some real excitement there. Because the peptides we have, the body wants to suck them back into the body, and they stick in the kidneys because you don't want to have protein in your urine. The body's doing what it does. Some of these other molecules don't have that, and they give a siting opportunity to remove the barrier of renal toxicity from the design. So in the interest of time, I'll stop there. I maybe hit on a few of those things.
I know we've got 1 minute left, Chad, and I know you're our timekeeper too. So because
1 minute left, I have several other questions we won't get to. So maybe for 2025 and are moving forward with future webinars, we can build a couple webinars around the questions that came in we couldn't answer. So with that, Geoff, Kathy, I would like to say thank you. Thank you all for joining our final 2024 webinar, and we'll see you again in 2025.
Happy holidays, everyone. Yes.